Hi, class. I wanted to go ahead and create a PowerPoint a voiceover for kidney transplantation. We're still dealing with these patients who have chronic kidney disease who are now possible candidates for renal transplantation. For patients to receive an organ, whether it be kidneys, liver, heart, or what have you, there is a candidate selection criteria. These patients are typically free of problems that might that may cause an increase in the procedural risk. Certain conditions might preclude or prevent these patients from having a kidney transplant. As far as donors are concerned, the available kidneys are matched based on tissue similarity between the person who is donating the organ and the patient who is receiving the organ. So there has to be a tissue. The tissues must be similar. The more dissimilar they are, the more likely they are going to reject the organ. Organs from living related donors, or we call them LRD, have the highest rates of kidney graft survival. So when you have these patients who donate an organ and they are alive, the recipient, they will likely have that particular organ for quite some time, in other words. There's also physical criteria that must be met. The patient cannot have a systemic disease or infection, no active cancer. The patient must be free of hypertension or renal disease, and adequate renal function is determined by a certain test that the patient might have. Now, again, as far as the candidate selection criteria, typically patients are transplanted when their age is 2 to 70. If they are greater than 70 years old, then they must be looked at on an individual basis. Patients with uncontrollable cardiac disease, metastatic cancer, chronic infection, severe psychosocial problems like alcohol abuse and chemical dependency are excluded from kidney transplantation. Also, certain GI conditions need treatment before a kidney transplant, or because large doses of steroids can make these conditions worse. So patients who receive a transplanted organ are actually placed on high doses of steroids. And so what it's saying is it can worsen these GI conditions. Patients with urinary issues must be evaluated before the kidney transplant. They must be free of cancer at least 2 to 5 years to be considered for a transplant. Patients with endocrine issues and diabetes are at greatest risk of rejection. As far as donors, donors can be living-related type. They can also be non-heart beating donors and also cadaveric donors as well. Available kidneys matched on basis of tissue type, similarity between the donor and the recipient. And some donor transplant centers require also a psych evaluation before donating as well. So you're looking at basically the whole patient, so to speak. So let's also get into the pre-op care or task that must be performed, and also some considerations regarding the operative procedures. Immunological studies are done on these patients in the pre-op period. This is done due to the major barriers to transplant success after a suitable donor kidney is available, because it is the body's ability to reject a foreign tissue. So tissue typing with human leukocyte antigen or HLA studies and body typing is done on all candidates. The human leukocyte antigen is the main immunologic feature that is used to match transplanted or transplant recipients with compatible donors. The more similar the antigens of the donor are to the recipient, the more likely the transplant will be successful and rejection can be avoided. Dialysis is performed 24 hours before surgery, and also patients might receive blood transfusions in that pre-op period as well. As far as the operative procedure, the new kidney is placed in the right or the left anterior iliac fossa. It's not actually placed in the area where the old kidneys or the non-functional kidneys are, but in the area I just mentioned, the iliac fossa. And this is because it allows easier connection of the ureter and the renal artery and renal veins to the new transplanted organ. It also allows for easier palpation for examination. Recipient's kidney also is not removed unless the patient has chronic kidney infection or a case of polycystic kidney disease or non-functioning enlarged kidney that causes pain. So this is where you can see placement of a transplanted kidney in the right iliac fossa. Remember, it would typically be a little higher than what you see here in this picture. As far as post-op care, there's a urological management that must be done. Assessment of hourly urine output is done for about 48 hours. Complications of kidney transplant are rejection, thrombosis, renal artery stenosis, and also some other complications, and we'll discuss these. And also, as far as the post-op care, these patients receive immunosuppressive drug therapy. So the most common complications after transplant are rejection and infection. Drug therapy is used to prevent tissue rejection, but because they're on these immunosuppressant, remember the immune system is being suppressed. The reason the immune system is being suppressed is because if the immune system is left to function normally, it can attack that foreign organ that the patient receives. Remember, that organ isn't supposed to be there, so the body's defenses of the recipient will view that organ as a foreign invader that is trying to wreak havoc. So therefore, they must be placed on these immunosuppressant drugs in order to kind of weaken the patient's immune system so it does not attack the new organ, and so that the organ can function for a certain period of time. Even though these patients are on immunosuppressant drugs, all patients reject the organ after a certain period of time. The organ is functioning well, the patient is on immunosuppression drug therapy, they're following the appropriate protocols and what have you, then the longer they will have that organ. I mean, some people have had kidneys for 15, close to 20 years. And as a side note, one of the organs that, each organ has a certain shelf life, if you will. Lungs have the lowest shelf life. I think they may be a few years, and that's because, when these patients are breathing in and out, those lungs are exposed to the environment, so they don't last that long. Now, when people are on immunodrug therapy, they do have decreased immunity, impaired healing, and also there's increased risk of infection because remember, the immune system is now made weaker to prevent an attack on the foreign, uh, organ. A Foley is also placed for better or strict intake and output. You also want to decompress or kind of deflate the bladder. You don't want the bladder to stretch because if it does, it can affect the sutures and the ureter attachment sites on the bladder. So that Foley, but the Foley is removed 3 to 5 days after surgery. So if you have a patient who has abrupt decreased urine output, that might mean rejection, acute kidney injury, thrombosis, or obstruction. Typically after surgery, the urine is pink and bloody after surgery, but it returns to normal after several days to several weeks. After surgery, the function of a transplanted kidney may result in either oliguria or diuresis, so they might have both. Remember, oliguria is about 400 cc's or less, and of course, diuresis is just putting out large amounts of urine. Oliguria can be due to ischemia, meaning ischemia, decreased blood flow to the kidneys, or acute kidney injury. Rejection could be due to that or other complications. Now, due to the increased urine output, I should say, to increase the urine output when these patients have oliguria, these patients are given diuretics and osmotic agents as well. And essentially, your duty as a nurse is to observe these patients' fluid status due to potential, for fluid overload that can cause hypertension, heart failure, as well as pulmonary edema, things you must look for in these patients in the post-op period. Now, sometimes instead of oliguria, these patients may experience diuresis, especially with living-related donors. So you must observe the patient's intake and output, their fluid and electrolyte balance, like low potassium and sodium levels. Increased diuresis can also lead to hypotension because they're losing so much volume. Complications of rejection. It's the most serious complication of transplantation and loss of the graft. The graft being the the organ itself, how it is grafted, how the organ is grafted into the patient's own system. Patients' defenses to treat transplanted organs like foreign invaders, or should I say, the patient's own immune defenses. They treat this transplanted organ like a foreign invader, as I explained earlier, and this can lead to tissue destruction, thrombosis, and kidney necrosis, meaning kidney death. I want you to go ahead and read a review acute rejection on page 1423. Review the table 6813. Now, thrombosis. This is a clot that occurs in the major renal vessel, and it occurs the first 2 to 3 days after the transplant. So be looking for that as well. As far as renal artery stenosis, which is another complication, this can result in hypertension and other signs and symptoms. Bruits, in other words, are actually heard when you take a stethoscope, develop the stethoscope, and you listen over the area located above the or on top of the renal artery. You hear like a whooshing sound, which is a bruit. And again, this is over the artery anastomosis, or where it is attached site. And this does lead to decreased kidney function. Other complications, there's wound problems like hematomas, abscesses, lymphocele, which are cysts containing lymph fluid. and this increased risk of infection and places pressure on the new kidney. Infection from reduced immunity is the major cause of death in these transplanted recipients. So for prevention, there must be strict aseptic technique and hand washing. Now, transplanted recipients may not have usual signs and symptoms because their immune system is so suppressed. So signs and symptoms may look like low fever, low-grade fever, mental status change. They may also have vague reports of discomfort that might precede or occur before sepsis. Look for urinary tract complications such as ureteral leakage, fistulas, or obstruction. There's also problems such as stone formation, bladder neck contracture after a rupture. As far as immunosuppressive drug therapy, immunosuppressed drugs are like your corticosteroids, your inhibitor of T cell proliferation and also activity. Drugs such as cyclosporin and tacrolimus are the main ones, but there are also mTOR inhibitors and monoclonal antibodies. Now, these patients receive a high dose inductive treatment from these drugs, and then they receive a low dose over the life of the transplanted organ. Immunosuppressive drug therapy as a maintenance drug dosage to keep maintenance blood levels so as not to reject the organ. Now, non-adherence can result in the loss of the kidney. Non-adherence to treatment regimen. Transplant recipients, they are at risk for cardiovascular disease, which is the most common cause of death, and they're also at risk for diabetes, cancer, as well as infection. This is what happens when your immune system is compromised, and theirs have to be purposely compromised in order to not reject the organ, whatever that organ is. We must especially observe high-risk groups for graft failure, which is typically African Americans, Hispanics, and also Native Americans. Now, as far as home care management of these transplanted patients, teaching is very important. Teaching about diet, about the different types of dialysis, vascular access, the need for a generator backup. I mean, just in case something happens at home and they need electricity to operate their medical equipment. And read the rest of that. There's some additional information there. There's also self-management education. You want to teach these patients how to better manage their condition in the home setting. Patients shouldn't be treated in the acute care setting unless they're absolutely necessary. So the better knowledgeable they are about their condition, the more they can remain in the community to continue self-care. Patients and families must be taught about nutrition and drug therapy and the complications. These patients must be taught to report fluid overload, signs and symptoms, and also about infection. Also discuss immunizations and about extensive training needed for peritoneal dialysis. And of course, there's some additional information in that section as well. There are some healthcare resources that the patient must be provided. With these patients, professionals from many disciplines are involved in their care, whether you be a physical therapist, a nephrologist, a social worker, a psych, etc. Tell them about organizations like National Kidney Foundation, American Kidney Fund, etc. For additional resources and support. These are just some identified priority problems with expected outcomes and appropriate management. We want to achieve and maintain appropriate fluid and electrolyte balance. We want to maintain an adequate nutritional status. We also want to avoid infection at the vascular access site. Want to use effective coping strategies. We also want to prevent or slow any systemic complications of CKD, including osteodystrophy. We want to also report an absence of physical signs of anxiety or depression as well. So these are some of the issues you will maintain as a priority when you're dealing with these patients. And that is actually it. We will go ahead and stop right here. So hopefully this information you will find to be very helpful for you. Of course, as always, if you have any issues or concerns, need better clarification in class, please make sure you talk to me. Thank you.